Hi, my name is Smear and I live in Dubai. I have been diagnosed with endometriosis, deep infiltrated endometriosis. I started experiencing symptoms about 3 to 4 years ago in intensity, and reached out to a couple of gynecologists and doctors at different hospitals in Dubai, but was struggling to find, first of all, a proper diagnosis, and then when they did identify it, a proper course of treatment. This is until I was referred to Dr. Gassan at Saudi German Hospital. He was amazing. He talked me through what exactly the issues were, what was causing my extreme menstrual cramps, pelvic pains, and also difficulty during bowel movement. He very thoroughly told me what my options were, and after several conversations with him, I felt comfortable enough to have a surgery to treat the condition.
So I think now if we start with the animation, so we can start with discussing the case of Miss Simi, which I spoke about. And I think that after meeting with her and examining her, and after doing the MRI and the pelvic ultrasound, I think it's very clear that this patient has a clear involvement of the bowel at this level, and that there is a nodule in the rectovaginal space, which is mostly causing the symptoms of the patient. As discussed with Dr. Manish, that we are going to perform the surgery laparoscopically, and we're going to prepare the patient before that surgery. And looking at the images, I think that we can manage to do this in a conservative way. Miss Simi came to me and she was complaining of pelvic pain, dyspareunia, meaning pain during intercourse, and pain during stool motion. And this has been going on for quite a long time, but has becoming worse during the last year. She visited different hospitals with no conclusive diagnosis or treatment. So basically, after doing the proper imaging in the hospital, both pelvic ultrasound and MRI, after even her performing MRI in other hospitals, which was negative, we came to the conclusion that she has a disease, endometriosis, which is involving the bowel and the rectovaginal area. So we discussed this with the team, and we agreed to proceed with surgical approach. And that's thanks to the multidisciplinary resources that we have here that allow us to put the right diagnosis and plan the proper surgery.
So whenever a patient is referred to us in the radiology department with the diagnosis of endometriosis, the first line of diagnosis is ultrasound, which can be transvaginal or transrectal depending upon the case. And though it needs a special training and expertise, but this is it's a very good tool in our hand to see the lower pelvic organs and the parts which will not be very accessible with the MRI. And plus, if done together in hand, it gives us better sensitivity. It can reach as high as 92%. And once the mapping of the endometriosis is done, then the case is discussed with the surgeon as well as for an MRI, and is referred for an MRI with the report.
For this patient, when I received request from Dr. Ghassan regarding the clinical symptoms of this patient, we prepare for a special protocol to do the MRI of the pelvis in such cases. We did MRI using different pulse sequences. We use special techniques to diagnose early pelvic endometriosis using contrast media. And for this patient, it was clearly that the lesion is infiltrative lesion, deep pelvic endometriosis between the posterior serosal wall of the uterus and the rectum. And it is clearly depicted. It is enhancing in post-contrast study and with restricted diffusion, which is characteristic findings of MRI. As all of us know that MRI is the best imaging modality to diagnose different forms of such disease.
So after Dr. Ghassan came to me with this patient's symptoms, and we discussed the case and imaging with the multidisciplinary team, and then we agreed upon that the surgery would be required. As a general colorectal and gastrointestinal surgeon, our role is to collaborate with gynecologists. We have been doing major resection surgeries where we remove the bowel, rectum and everything. But those cases are like aggressive diseases like cancers and all. But here we have to find a fine balance between providing the cure, symptom-free life along with not having a surgery which will create more troubles for the patient in future. Endometriosis is something new for us, and we also keep learning from our gynecologist colleagues that it invades the tissues like cancer, but still it's a benign disease. So we have to remove it completely, but at the same time without affecting the inner anatomy and organs and preserving the function as much as possible. We have a variety of options available here where we can remove the part of the nodules in the form of shaving or disc excision, or sometimes if required, and if it is involving the bowel to the thickness of the full thickness inside, then we might have to consider resecting it completely. Definitely these approaches depend on the patient's clinical symptoms, presentation, their needs, demands, and the future plans of preserving fertility and the functions. And the multidisciplinary team is kind of a proper area where this can be discussed and decided upon.
I had my surgery last year and my recovery has been good after that. I'm experiencing a significant difference in my quality of life, less pains, elimination of random bleeding, which was happening previously, and I'm just able to operate better than I was before. I think it's very important for women to listen to their bodies and to trust their instincts when they feel that something is wrong, especially with endometriosis. It's not an easy condition to diagnose, but with the right doctor, you can find the right solution and how to manage it for the rest of your life.